I'd like to welcome everybody to today's presentation on the pharmacology of stimulants, the 2024 update. I'm your host, Dr. Donal Snipes, and this is part of the Addiction Counselor Training Series, although it is useful for continuing education for mental health counselors and social workers. So whatever letters you have after your name, welcome. In today's presentation, we'll review the neurotransmitters impacted by substance use and addictive behaviors and explore the mechanism of actions, symptoms of intoxication and withdrawal, and possible side effects for stimulants, including cocaine and crack, amphetamines, and methamphetamine. So let's talk about neurotransmitters really quickly. And why are we doing that? Because the mechanism of action, the effect that any substance has, whether it's a depressant or a stimulant, has on the body is because of the way it impacts the neurological system, the way it impacts those neurotransmitters. If we understand that, then we can start to understand possibly why some people may, quote, self-medicate their depression, their anxiety, their fill in the blank with certain things. We also can understand why, for example, with people with ADHD, they take stimulants and it has a different effect on them than a person who may not have ADHD. So, dopamine is the first one we're going to talk about because when we talk about addiction, dopamine is the one that most people think of. But as I've said before, and I'm going to say again at some point today, the neurotransmitters, and there's a lot of them, but the ones we mainly talk about are dopamine, serotonin, norepinephrine, GABA, glutamate, and acetylcholine. Those are your big six, if you will. And when one of those is altered, it alters everything else. They're supposed to stay in a certain balance. When you're in fight or flight, they're supposed to be in one configuration. When you're in rest and digest, it's supposed to be in a different configuration, but it's supposed to be in balance. So when dopamine's altered, it's going to impact serotonin and norepinephrine and all of them. Dopamine is important in regulation of movement. We know that people who have restless leg syndrome, for example, have problems in their dopaminergic system. We know people who, moving on, cognitive processes, including motivation, attention, and working memory, are also influenced by dopamine. Dopamine is your motivation chemical. Now, dopamine and your endogenous opioids kind of are buddies. So when we do something that is promoting our survival, your brain goes, hey, let's keep doing that. So it secretes more dopamine. When we do something that's pleasurable, the brain says, hey, let's do that again. So it secretes more dopamine. Dopamine is not as much about the pleasure, although it is somewhat involved in interpreting the stimuli, but it is definitely involved in motivating our actions, whether we're going to do it again or not. It's important in mood regulation. People with low dopamine often feel depressed. It's important for energy. And in the video I do on dopamine, I go into great detail about this. But suffice it to say, people who are on antipsychotics, for example, that lower dopamine levels tend to have really low energy. And that's a side effect that some people who are on mood stabilizers and antipsychotics medicate with nicotine and caffeine, two of the most commonly misused and potentially abused substances. And it's involved in, I said movement already, movement and movement disorders. It's the primary neurotransmitter involved in your reward pathways. When that endogenous opioid is secreted, when you're, and sometimes when your endocannabinoids are activated, if you will, and those are both pleasure, opioids and cannabis, if you want to think about it in terms of exogenous substances. When those are activated for some reason, the brain goes, ooh, I want to do that again. So dopamine is secreted. Dopamine is also secreted when we're in fight or flight because it says, hey, I'm going to motivate you to get the heck out of here. Noradrenaline and norepinephrine, whatever you want to call it, is part of the sympathetic nervous system. It sympathizes with us, if you want to think about it that way. When we're stressed, our norepinephrine goes up. When we're not stressed, our norepinephrine goes down. But it's not just a stress chemical. It's involved in mediating cardiovascular effects. It's involved in arousal, concentration, attention, learning, and memory. When noradrenaline is low, we tend to have a lot of brain fog and low motivation, which is not uncommon in people who are depressed. Now, again, think about when you increase noradrenaline, you also probably are increasing serotonin some because they move kind of in sync. Why is that important? Well, we're going to get into it in a minute, but when we use stimulants, it triggers the stress response. And what chemical do we all think about when we have a stress response? Adrenaline. I had an adrenaline rush. When our stress response is triggered, adrenaline goes up, as does dopamine to help us get motivated to get the heck out of there, and serotonin may come up with it as well. Serotonin is another neurotransmitter. It's the one we typically think of in terms of people who are depressed. If they have too little serotonin, they feel symptoms of depression. Too much serotonin, they feel symptoms of anxiety. That is grossly oversimplified. Serotonin has its grimy little mitts involved in everything. It's in our gut. It's in our brain. It helps regulate our platelets. It's in our helps regulate our heart rate. Serotonin is really a very interesting neurochemical. It's also known as 5-hydroxytryptamine or 5-HT. You don't need to know that for the quiz. I just thought it was kind of a cool little fact. So when somebody's talking about 5-HT, you know that they're talking about serotonin. Now, well, I won't get into that. That's for a different presentation. The functions of serotonin are to regulate smooth muscle function, your blood pressure, your peripheral and central nervous system neurotransmission, mood, appetite, sleep, cognition, perception, motor activity, temperature, pain, sexual behavior, and hormone secretion. Serotonin doesn't do that all by itself, but it is important, again, to just recognize if we're monkeying with any of the other neurotransmitters, we're going to be monkeying with serotonin. And so some of the physiological symptoms that people may have, including in addition to their mood symptoms, may be the result of dysregulation of the stress system. Dopamine, serotonin, norepinephrine, GABA, glutamate, and acetylcholine all act in a group, and they all have multiple systemic functions. That's the big takeaway you need to know. Dysfunction happens, and this is something that's important to recognize. We oversimplify when we say we increase dopamine or we're increasing serotonin or decreasing dopamine. Well, maybe not. Dysfunction symptoms like low energy are common to not enough norepinephrine, not enough serotonin, not enough dopamine. So we don't know exactly which neurotransmitter is out of balance, but when we increase serotonin, dopamine and norepinephrine tend to go up too. Your SSRIs are only one type of antidepressant. You also have SNRIs, selective norepinephrine reuptake inhibitors, and SNDRIs, selective serotonin, norepinephrine, dopamine reuptake inhibitors. So, and all of those fall in the antidepressant class. They recognize how all of these neurotransmitters may be implicated in certain people's mood. Additionally, and I know I'm kind of off in left field, we'll get to stimulants in a minute. Additionally, when neurotransmitters, the big six here, also impact the regulation of your thyroid hormone and your sex hormones, your estrogen, your progesterone, your testosterone, your oxytocin. So it's important to remember or recognize that all of these systems are intertwined. If someone is artificially increasing the excitatory neurochemicals, it's going to have downstream effects. When we talk about neurotransmitters, it's important to remember that dysfunction happens when there's not enough or too much is created. When people don't eat the right foods, for example, or they don't absorb the nutrients they need, they may not be able to make enough, fill in the blank. Not enough or too much is released. Let's think about serotonin or dopamine. We know that both of those, when you have too little or too much, you have mood and physical symptoms. So if somebody is having symptoms, we say, anxiety, for example, we may say their serotonin may be too high. That's not necessarily true. Too much could have been released. It could have been left in the synaptic space for the wrong amount of time. The way our neurons work, or are supposed to work, is that the body receives a signal. It squirts out a little bit of neurotransmitter into this synaptic cleft. And while it's sitting in there, it does its job activating the receptors on the other side. And then eventually enzymes come in and break down those neurotransmitters and they're reabsorbed and the process starts all over again. If it is sucked out of the synaptic space too quickly or broken down too quickly, or if it's left in there for too long and it hyperstimulates the receptors, both of those can be problematic. When the receptors are over-responsive to the stimulus, whatever that is, we call this reverse tolerance in addiction, but sometimes our receptors become very, very sensitive. And that over-responsiveness can cause people to feel excited. If you know people who are sensitive to caffeine, they have receptors that may be oversensitive or over-responsive to stimulation. Same thing is true with Sudafed or pseudoephedrine is the generic. That's a stimulant, and some people can't take it because it just sends their blood pressure up and their heart's just a racing. And other people can take it and they're just like, it's another day. Or the receptors can be tolerant or unresponsive. Just like in addiction, the dopamine or norepinephrine is there in the synaptic cleft and it's trying to get these receptors to wake up, and the receptors are saying, go away, kid, you bother me. I'm not going to pay attention to you right now. So the signal doesn't get transmitted any further. Or there can be a breakdown in the neuron to neuron messaging. And I don't know how many of y'all will remember this. Those of us who are from the last century remember when we were kids doing this thing called telephone, and you had two cans connected by a string, and you would talk to each other. Or you could do it another way, and you'd whisper to one person who would whisper to the next person who would whisper to the next person, and so on. And the message was usually completely screwed up by the time it got to the end of the chain. And that can happen in our nervous system if there's a breakdown in communication. So all of those things are important because when people start misusing stimulants, they're going to cause dysregulation in the nervous system. The HPA axis is going to start protecting itself, and it's going to start usually becoming tolerant to that stimulus. So if you used to be able to drink 1 cup of coffee and feel really good, and now it takes half a pot, that's evidence of tolerance. And like I said, some people will develop reverse tolerance where they actually they can't even go near it anymore. Please like, share, and subscribe. It really helps. Our numbers are down on the channel right now, and it would be a great favor to me if you share this with anybody who would benefit. Other important terms. Tolerance is when the receptors start not reacting to the stimulus. You're just like, the receptors don't even register that they're being stimulated. Cross tolerance is when you become sensitive to similar drugs. Instead, if you're abusing caffeine, for example, and then you take Sudafed, that has stimulant properties. It's not the same drug, but it has stimulant properties to it. You may also become more sensitive to alcohol as a result of stimulant misuse, because when alcohol leaves the body, the GABA leaves the body. It's not being activated anymore. So the glutamate is just completely unopposed, which is why people's blood pressure goes up. So it's important to understand that when the nervous system is responding to a stressor, that stimulates the same neurochemical reaction that you're stimulating with stimulants. Physiological dependence is when the body comes to rely on it. You just can't go unless you have that drug in your system. And physiological dependence with stimulants can even include blood pressure and heart rate. Some people, if they've been abusing and they've developed a physiological dependence on stimulants, if they're not using a stimulant, if they don't have it in their system, they may develop what they call bradycardia, which is a slow heart rate. So it's really interesting. Withdrawal is another important issue. And again, I'm going to stick on caffeine for a minute because most of us drink caffeine. It says, one study I looked at said that 92% of adults drink at least one caffeinated beverage a day. Okay, so that's fine. We do that. That's not abuse. But for people who do overuse it and their body gets used to it, if they're drinking coffee from the minute they wake up to the minute they go to bed, and they wake up and they got to have an eye opener in order to avoid getting a headache, then that's a withdrawal symptom. The half-life of stimulants varies depending on the drug. The half-life is the amount of time it takes for half of the original dose to leave the healthy, under 60-year-old body, not on any other medications. Now, generally, people just say the first part, time for half of the original dose to leave the body. That's true. But when we look at typical half-lives, they're based on someone whose liver is healthy and can effectively clear that. Once we get older, and if you've lived a healthy life, generally that's 60 years and above, your liver starts slowing down. It starts having more difficulty clearing some of these substances from the body. So if you're working with an older adult, it's important to recognize that. It's also important to recognize that a lot of medications and a lot of stimulants are metabolized by cytochrome P450. They're cleared from the body by cytochrome P450, which is a group of enzymes. And if you take one drug, let's say diphenhydramine, which is metabolized by cytochrome P450. So you take Benadryl in the morning because your allergies are just acting up. And then you drink caffeine later, they're going to compete because cytochrome P450 is trying to eliminate the diphenhydramine from your body. And so there's not as much extra to try to eliminate the stimulant. So the stimulant, if you take it second, their belief is will stay in your system a little bit longer than not. Now, that's obviously not suggesting to try to do it that way. Different drugs in the same class have different half-lives. Caffeine, and I did this even though Cocaine, you almost never take it orally. I wanted to compare oral to oral to oral. So caffeine, when you take it orally, has a half-life of 5 hours. So if you drink caffeine at 5 p.m., half of it has gotten out of your system by 10 p.m. And then the rest of it theoretically will get out of your system in the next 5 hours. But that's when you're supposed to be sleeping, not stimulated. Oral methamphetamine takes about 5 hours to clear the body. And what we're talking about here can be illicit methamphetamine or oral stimulant drugs like some of your weight loss drugs and your ADHD drugs. And then cocaine, either oral or inhaled, tends to have a half-life between half an hour and 1.5 hours, with the average being about an hour. So when people are using, this is how long it takes before they start feeling, in general, feeling like they may want another fix, or they aren't feeling the effects of it as much anymore. Ecstasy and amphetamines are metabolized by cytochrome P450, as are SSRIs, mood stabilizers, antihistamines, and a whole list of other drugs. That's important because that means that the caffeine may be having a stronger impact on the fight or flight system than we're recognizing, because they're competing for those breakdown hormones. Caffeine may take longer to get out of the body because the body's trying to get the SSRIs metabolized first. And we want to be cognizant of that. Again, a lot of people will self-medicate the side effects of some of their medications, like antihistamines. I know if I take one Benadryl, I'm, out of it. So if I have to take a Benadryl for some reason during the day, I'm drinking some caffeine in order to try to balance it out, to turn on that HPA axis, that stress response, in order to give me energy to get through the brain fog that I feel when I take antihistamines. Our schedules, and this is just kind of an interesting fact. Schedule 1 drugs have no known medical use and a high potential for abuse. Now, I found it interesting that Schedule 1 drugs, and I double-checked my sources, ecstasy and MDMA are Schedule 1, okay, but so are LSD and cannabis, which we know are both being heavily researched right now for the treatment of PTSD and depression, among other things. And then heroin is also a Schedule 1 drug. There are alternatives to heroin that are theoretically less abusable. Schedule 2 has known medical uses, but has a high risk of abuse and diversion, which means people get prescriptions and try to sell it. Fentanyl, your ADHD meds, your stimulants, cocaine, and methamphetamine. Schedule 3 are drugs with moderate to low potential for abuse and diversion. And one example they gave was anabolic steroids. Now, I think those have a relatively high diversion risk, but maybe that's just me. Schedule 4, drugs, and this one made me laugh. Drugs with a low risk of abuse and dependence, including Xanax, Darvon, Ambien, and Tramadol. I've worked with people in substance abuse for many years, and I know today we're talking about stimulants, but Xanax and Darvon and Darvocet are very commonly abused and misused by people. So just because it's a Schedule 4 and your person is on it, don't assume that they're using it as prescribed. And then Schedule 5, these are the drugs with lower potential for abuse than Schedule 4, like cough syrup with codeine. Methods of administration, and you can administer all of your stimulants any of these ways. It's important to understand that inhalation and injection produce the fastest route for the stimulant effect for the stimulants to cross the blood-brain barrier. So we do want to understand that if your person is smoking it or injecting it, then they're going to get a really fast response. You can inject it either intramuscularly, intravenously, or subcutaneously, which means like right under the skin. You can smoke it. You can inhale it, snort it. You can administer it rectally or vaginally through like a suppository. Sublingually, which is under your tongue. Buccally, which is between your gum and your cheek. Transdermally with a patch. Or you can just take a pill. So there are a lot of ways that substances can be taken, and helping people recognize the impact of those substances and being aware if you're screening somebody for misuse that, asking them about pills may not, or caffeine may not be sufficient. They may be ingesting it other ways. Cocaine is both a local anesthetic and a central nervous system stimulant and is the most potent stimulant out there. It's not used much anymore, but it used to be used for ear, nose, and throat surgeries for numbing in a cream formulation, but they've found alternatives now that they're using. So that's kind of going out, but it's still available to certain practitioners. Cocaine increases the release of dopamine by 1,000%. So that, I want to do that again, is amped up 1,000%. Now, I know when I get driven to do something, I'm, a force to be reckoned with. I can only imagine what I'd be like if I was amped up 1,000%. Crack is the rock form of cocaine and can be smoked. Ecstasy and MDMA is another form of stimulant, which, of course, some of the people may be experimenting with using recreationally. And using recreationally generally doesn't have long-term effects on the central nervous system. It can be sort of a gateway to abuse. And again, if somebody is on other drugs that are competing with that stimulant for excretion from the body, it may make the impact of that drug stronger, more impactful, and cause damage quicker than if they weren't taking those two substances together. Bath salts are also stimulants, as are ADHD medications, and you'll find methylphenidate or dexmethylphenidate are two of the most common. And then many of your substances that end in INE are stimulants. So when you're going through somebody's history and you see caffeine, nicotine, pseudoephedrine, I know it's pseudoephedrine, but or ephedrine, then we're talking about stimulants here. Atomoxetine is another one. Yohimbine, which is from the yohimbe plant or something. And a lot of people take that over the counter. It's a stimulant. If you've got clients who are stimulant sensitive and they're starting to look at over-the-counter supplements to help them lose weight or something, they may gravitate towards stimulants like yohimbe, as well as some of the others that, too long to list. It's important for them to understand that the stimulants can be really impactful for them. If they may be reading the nutrients and they're like, okay, I don't see guarana and I don't see caffeine, so this is good. I can take this and I'm not going to feel like I'm going to crawl out of my skin or it's going to send my blood pressure through the roof. No, check again. Phentermine and dexfenfluramine were both prescribed for weight loss a decade or so ago. They're still available some, but just being aware. Again, we're not prescribers, and I can't possibly cover all the stimulants out there. I'm just trying to give you an awareness when you're looking through people's substance use history as well as their medication history to be aware of what they're taking. If they're taking pseudoephedrine every day for something, we may want to look at that. Stimulants are the most frequently used drugs in the world. They're used to prevent fatigue. They're an appetite suppressant. They improve concentration in people with ADHD. They're used to treat clinical depression, which, that one made me think for a second, but especially in older adults, apparently, caffeine is one of the interventions they're using to help address symptoms of clinical depression. Now, it doesn't do everything, but some people may start self-medicating their clinical depression early on with caffeine when they feel like they've got no motivation, they can't get up, or when they're getting to that point of burnout at work, they may start, just pounding back the coffee to try to get through the day. And we want to look at whether the caffeine is serving a helpful function or it's actually causing greater dysregulation of the stress response. It's used to reduce fluid retention. Another thing to remember, when people are using stimulants, and I'll reference people specifically on antipsychotics, but it's true for all of your other drugs, your antidepressants, etc. But many of our drugs are sensitive to the blood plasma levels. And when we get dehydrated, our blood plasma levels of the drug are altered. And people who become dehydrated often, who are on antipsychotics, for example, often experience a psychotic episode. And we see a lot of breakthrough in psychotic symptoms during the summer in the South because people who have who are on antipsychotics are sweating. I mean, you can't walk to your car without sweating. So even if you've got air conditioning, if you go outside, you're sweating. And they may inadvertently get dehydrated. If they're also, which most people on antipsychotics want to do, if they're also using nicotine and caffeine, both have fluid reduction aspects to them, then they are making it even more likely that they're going to get their blood plasma levels of their medication out of whack. We do want to pay attention and educate clients. I'm not saying tell somebody who, is on antipsychotics and drinks caffeine and smokes, well, you can't do that anymore. But they need to be aware. They need to monitor their hydration levels, their fluid levels, in order to make sure that they're not getting out of balance. They need to be conscious of their symptoms, and if they start getting some prodromal symptoms, symptoms that precede a full psychotic episode, they need to take action, toot sweet. It can be used as an anesthetic, like I said, and that's cocaine. Cocaine is the only one that is used as an anesthetic, and that's going out now. Thank you. And it can be used to treat respiratory issues. And that one kind of made me scratch my head for a second. But then I started thinking ephedrine, pseudoephedrine, Sudafed, the decongestant that a lot of people have turned to for the past 40 years or more in order to breathe better when we get sick. So, and that's a stimulant. I know for me, I am extremely sensitive to stimulants, and including ephedrine, including caffeine. And I developed a reverse tolerance to it as a result of using workout supplements back in college when they were still using ephedra and some other really, really potent stimulants in some of the workout supplements. And I've never really completely recovered, but I recognize that. And I understand that I am hypersensitive to stimulants. So how do stimulants work? They trigger the HPA axis, which is your stress response. and they cause the release of excitatory neurotransmitters and hormones. Spelled that wrong, sorry. They release norepinephrine, noradrenaline, glutamate, which is your main excitatory neurotransmitter. Its main function is to give you energy. Norepinephrine helps you focus, helps you think, and it gives you a little bit of energy. Glutamate gives you energy. Dopamine motivates you to resolve the threat. You're triggering the stress response. That means that there must be a threat. So dopamine says, all right, let's go figure out what we need to do. And cortisol is another stress hormone that's released when the HPA axis is triggered. Cortisol is really helpful as an anti-inflammatory when it works. When the HPA axis starts to get dysregulated, these things start to lose their effectiveness. The dopamine-rich areas of the brain in the reward pathway are the ventral tegmental area, the nucleus accumbens, and the caudate nucleus. Again, don't need to know that for your quiz, but it is interesting to recognize that there are dopamine clusters of dopamine receptors in multiple different areas of the brain that serve multiple different functions. There are also dopamine receptors throughout your whole body, as are serotonin receptors. Increased dopamine and norepinephrine impact the brain in 4 ways. It binds to the presynaptic membrane, causing the release of dopamine. So take the stimulant, they bind to that presynaptic membrane, and they say, let's release the dopamine. Open up the doors. They interact with dopamine containing synaptic vesicles. Sorry, I can't talk today. And they release free dopamine into the nerve terminal. So that synaptic cleft out there is going, woohoo, we got lots of dopamine and other stuff. They bind to monoamine oxidase in the dopaminergic neurons and prevent the degradation of dopamine, leaving free dopamine in the nerve terminal. Remember, I talked earlier about how once it's secreted, it sits in that space between where it was secreted from and the receptor. And it agitates the receptor neurons to say, hey, open up and let us through. And I always imagine it knocking on a door. Sorry, that's why I do that. But when people are taking stimulants, what it does is it binds to the enzyme that normally breaks that down and lets the dopamine just sit in that synaptic space for a lot longer than it's kind of supposed to. And that agitates or hyperagitates the nerve terminal. It binds to the dopamine reuptake transporter, causing it to act in reverse and transport free dopamine out of the nerve terminal. So instead of sucking it up after it's been sitting in that nerve terminal, sucking it up, it actually secretes dopamine into the nerve terminal. Think about using one of the wet vacs. I've used those before where I've thought I've had it plugged into the right thing and I was going to suck a bunch of stuff out, and I ended up having it on the wrong end, and I blew water out all over the barn floor. It was a mess, but anyhow, stimulants affect everyone differently based on their physical size. An 80-pound person is going to react differently to 5 ounces of coffee than a 200-pound person, regardless of muscle mass, fat mass, anything. This is just going to happen. Their weight and their health. As I mentioned earlier, somebody who has poorly functioning liver is going to have a harder time clearing the stimulants. They also may be more sensitive to it because of prior exposures like I am. Whether the person is used to taking it. If somebody has never had caffeine before and you take them to Starbucks and they get whatever the highest caffeine espresso is, and they take that, they are going to feel like they're going to crawl out of their skin because their receptors have never encountered that before, and they're just getting flooded with dopamine and adrenaline and all this other stuff. If you have been going to Starbucks and getting espresso for a year or so or more. Now you can probably take that and yeah, you get a little bit of a caffeine rush off of it, but it's not anything like the first time because your receptors have become tolerant to it. So now it takes more caffeine, just like any other addiction. It takes more of the stimulant to get the same stimulation. The effect is different whether they're taken with other drugs or like over-the-counter drugs or other illicit drugs. If you're drinking caffeine and taking cocaine, that's a double whammy. If you are, and this is one of the things that I feel kind of bad for people for, if you are drunk and you're starting to sober up, naturally your stress response is kicked off because that glutamate is unopposed now. So people tend to have a spike in their blood pressure, a spike in their anxiety. But if you're trying to quickly sober somebody up by giving them coffee, number one, it doesn't work. You just have a wide awake, really anxious, drunk person. But this stimulants, the coffee, is going to have a stronger effect because the stress response is already in overdrive. Depends on the amount taken, the method of administration, we talked about that. I don't think most people are going to snort caffeine, but you take it orally, takes longer to get into your system. People who use nicotine products, if they smoke it, it's going to go and have its effect faster than if they're, chewing, if they're doing it buccally. And the strength of the drug. With illegally produced drugs or naturally produced drugs, things that aren't produced in a lab, the intensity, the strength varies from batch to batch and may even vary within batches. Caffeine is, I would say probably pretty standardized across different batches of the same type of coffee, but coffee even varies in the amount of caffeine it has in it, depending on the coffee bean, etc. Signs of intoxication. This is what we want to be looking for in our youth, in our clients when they're in our office. Generalized euphoria, increased energy, confidence, mental alertness. Now, as with everything, we're talking about a continuum. If you drink a little coffee to help you get a better attitude and get some energy to start the day, not a big deal. That's not causing you clinically significant problems in any area of your life. It's not harming your body. But if the person is overly euphoric, if they are hypomanic, if they are too confident, mentally alert, sexual arousal is another one of those that they become hypersexual when they engage or when they administer a stimulant. That's something to be aware of. It's also important to be aware of the effects of stimulants like ecstasy on someone's judgment when they are regarding sexual activities. Are they going to be clear-headed enough to make a good judgment? Other signs we can look at. If somebody is regularly itching and scratching and they haven't been in poison ivy, that can be a sign of stimulant intoxication. If their pupils are blown, they're like really wide, it's bright in the room, so their pupils should be smaller, but their pupils are dilated like nobody's business. That's what we call a clue. And it's the opposite for opioids. If people are taking opioids, their pupils are usually pinpoint. Rambling speech, that's not typical for them. High blood pressure, fast heartbeat and breathing, teeth grinding. These are all stress responses. Your body's trying to give you the energy. Your heart's pumping blood saying, let's fight or flee, fight or flee, fight or flee. And if you're just sitting there, it'll probably feel a little bit uncomfortable, which is why a lot of people who are intoxicated with stimulants tend to be more agitated. They want to get up, they want to move around because their body is telling them to fight or flee. Teeth grinding is another side effect of stimulants. Dry mouth. Remember, stimulants are diuretics, and when people use them or abuse them, then you don't have as much saliva. Reduced appetite. It's not time to rest and digest. It's time to fight or flee. Excessive sweating. Your body's trying to keep itself cool and regulate the system. Think about when you go to the gym. Well, typically when your heart is racing and you're breathing really heavy, you're engaged in some sort of strenuous activity and your body's trying to keep you cool while you're doing that. Your temperature goes up, which can also mean you get chills. If your temperature goes up, think about when you've got like 104-degree temperature or something, God forbid, you typically want to cover up with blankets because you're freezing. You're 104, the room is 72. There's a big difference. You can imagine how uncomfortable that might feel. Increased blood sugar for your clients who are diabetic or pre-diabetic. This is an important thing to be aware of. Nicotine, caffeine, and any of your other prescription stimulants will cause the body to dump blood sugar. It's what happens when we trigger the fight or flight response. And there's increased mucus, runny nose, and sometimes there's extra saliva in some people. Other possible side effects that are more on the I've abused them or I've overdosed: hostility, irritability, paranoia, psychotic symptoms, unsafely elevated body temperature, irregular heartbeat, heart failure, stroke, and seizures. So stimulants are nothing to just play with. Now, you can drink a lot of coffee and you're probably not going to get to the point where you stroke out unless you already have hypertension. But some people will drink coffee and take things like NoDoz at the same time. And that's just way too much caffeine for your body. And that can actually send you into a hypertensive crisis. When I was in school, I don't know how popular it is now. When I was in school, a lot of people took NoDoz in order to not have to sleep as much, which has its own set of problems. Remember, when we're not getting enough sleep, we're not clearing out the adenosine, we are also dysregulating the stress response because the body recognizes a lack of sleep as a threat. You're not as alert. You're not as prepared. You don't have as much energy. When you don't get enough sleep, your body doesn't repair itself as well. So it can predispose people to depression, to anxiety, to mood side effects, to low motivation, which they may present with as a symptom. They're like, "Doc, I don't know why I'm depressed, but I have no motivation. I don't feel much of anything anymore." And we find out, lo and behold, they have been pounding back the caffeine and these various over-the-counter herbs for 6 months. Stimulant withdrawal is typically the opposite of intoxication. So if you're taking a stimulant, it triggers the fight or flight response. When you are withdrawing from it, the body is going, "Oh my gosh, thank you, give me a break." So you're going to have depression. But the body also recognizes that things are all out of kilter. Neurotransmitters are all out of whack. And there's been damage done because having the stress response, having the HPA axis activated for that long may have caused some neuronal damage or whatever. So you've got a tired person that also has some anxiety and irritability because they don't feel well. Restlessness and agitation, mood swings, drug cravings, if they are tolerant, if they are physiologically dependent or even psychologically dependent, they may just be like, just give me one dose to get me through this, because the brain is deficient now. If you're not hyperstimulating it, then the brain's going, well, you were given this to me, then you quit. Where did it go? Give it back. Give it back, please. And it takes a while for your natural hormone systems and neurotransmitter systems to kick back in and realize that you're not going to get it the easy way anymore. You got to make it. There can be difficulty concentrating. Well, adrenaline, we already spent that, so to speak. So concentration out the window. Loss of interest. Dopamine. We have just used the crap out of the dopamine and overstimulated the dopamine system, so it's resting. It's go away, kid. You bother me. You may see some paranoia and hallucinations, fatigue and exhaustion. Again, the opposite. The body's going, oh my gosh, I can rest. And by the way, I don't even have enough cortisol to do my normal peak and decrease. Increased appetite. Well, that's that rebound. Sleep disturbances. Some people will actually have insomnia, which seems counterintuitive, but because if they're so addicted to the stimulants that they're going through powerful withdrawals, it may trigger the stress response. The body's like, please give me more so I can balance myself out, which can cause them to have insomnia and agitation. Most people, after working on a detox unit for, many years, most people who abuse stimulants have hypersomnia. You can't get them out of bed. Body aches, chills and sweating, again, slowed movements in speech, and headaches. And just think about detoxing from caffeine. You can have one doozy of a headache just from, caffeine. And that's not even necessarily using a whole lot of it. The withdrawal timeline typically follows this pattern. Symptoms begin within hours to several days after the last use. The most intense symptoms peak around 1 week. Now, this is for people who are tolerant and quit cold turkey. Generally, the most intense symptoms peak around 1 week. Acute withdrawal lasts about 7 to 10 days. And some symptoms, especially psychological ones like anxiety and depression, can persist for weeks or even months. And we call this post-acute withdrawal syndrome. And I do have videos on that too. The severity and duration of withdrawal can vary based on the type of stimulant used. Again, if you're talking about detoxing from caffeine, that's going to be a much easier withdrawal compared to detoxing from methamphetamine. The duration, method, and intensity of use, the person's individual physiology, and the presence of co-occurring mental health disorders. I guess Boo wants to join the class. Long-term effects of stimulants include dry mouth and dental problems. When you have dry mouth, it allows dental problems to develop. And my dentist explained it to me one time, but we do know that people who are chronic methamphetamine users tend to have really bad oral hygiene. Reduced immunity. When that stress response is dysregulated, it leads to increased systemic inflammation and alteration and reduction of the immune system. Trouble concentrating. And, well, if you have made the norepinephrine, the noradrenaline receptors tolerant, then it's going to take more in order to get them to activate. We know that they help us focus, so we start seeing people have difficulty functioning, difficulty concentrating when they're not on stimulants. Difficulty breathing, muscle stiffness, anxiety and paranoia, depression and suicidality. And this is significant in people who are detoxing from stimulants in a lot of cases. So we don't want to ignore this. If someone is self-weaning off of some sort of stimulant. Maybe they got themselves in a bad way and became dependent on a prescription stimulant that was not prescribed to them, or they were overusing what was prescribed to them, then it's important to help them recognize that they may feel very depressed for a little while because their neurotransmitters are just all out of balance. Heart and kidney problems. Oh, and with that, of course, we want to take adequate, appropriate steps to make sure they're safe. Heart and kidney problems. When you're regularly overtaxing the heart and the kidneys, they're going to experience strain, if you will. And without getting into huge detail, because we don't have time for that, just be aware that somebody detoxing from stimulants does need to have a thorough physical. Increased risk of stroke, tolerance to the stimulants, confusion, especially when they're not on stimulants, sexual dysfunction, again, especially when they're not actively using. Remember, using increases libido. Well, not using may decrease libido, even lead to sexual dysfunction. Chest pain or palpitations, and seizures and delirium. Stimulants are a class of drugs that trigger the stress response and release a flood of excitatory hormones and neurotransmitters. It's like you are just in this huge adrenaline rush. There are legit uses for stimulants, but some of the stimulants are very prone to abuse. People taking herbs and prescription medication may be more sensitive to the effects of stimulants, and we need to just educate them about all of the different herbs and over-the-counter things and even foods that can be stimulant in nature. If you're interested in learning more about cytochrome P450, that enzyme that helps break down the stimulants and get them out of the body, you can go to the Drug Interactions Flockhart table. Just Google that and it'll come up. Or if you're in the class, you can click on the link from the PowerPoint. But that will give you information about which drugs use the same cytochrome P450 enzyme in their metabolism, which I think is interesting, but maybe you don't. Anyhow, I know pharmacology can be a very dry topic, so I appreciate all of y'all hanging in here with me. Are there any questions? I'm glad we had a lot of four-legged students today. Most of them probably don't need stimulants. I know mine don't. Actually, my boxer's on thyroid medication, but that's a boxer thing. But interestingly, total side note, did you know that hypothyroid can actually contribute to high cholesterol levels? His cholesterol levels were through the roof. And once we got his thyroid in balance, his cholesterol levels went down. Likewise, thyroid, that's another stimulating hormone that we release in the stress response. And so we can see, even though I didn't mention it in the presentation, we can see some people developing hypothyroid, even autoimmune hypothyroid, as a result of stimulant abuse. Jay Holmes, yes, I do have a lot of other videos related to pharmacology. They are older. I'm in the process of updating and re-recording them now. But if you look on the YouTube channel, I do have cannabis and alcohol and depressants and opioids and everything out there. I teach as part of the curriculum for all CEUs, I do teach the addiction counselor certification track. So I have to have those videos available and the information available for people.